SAD stands for with this?
Actually, no, I don't. Is it the seasonal affective disorder?
Yes. Yep,
Okay.
you got it. So it's fall or winter depression. A lot of times you'll see them go to tanning or use some kind of light therapy. Actually, Ohio is one of the worst states to have this because we have the cloudiest days in the winter. I know Alaska, they're big for this also. So it happens to a disturbance in the sleep and wake cycle system of the body. Some other mood disorders it talks about in your book is postpartum depression. This can be onset of 4 weeks after delivery. Years ago, there were some cases, a woman drowned her kids in a bathtub, another one drove into a lake and all the kids drowned. So, this is very, very serious. So, but now, I don't know if any of you have had babies recently, but I'm hearing from my niece, they have one. They assess this really good now after a baby is born. So that's good. They didn't when I had my kids, knew nothing about it. There's also postpartum psychosis, which is very severe and it occurs like days after delivery. So you're not in the hospital that long anymore, so it's hard to assess a lot of this. Excuse me. There's also non-suicidal self-injury. So this is, they're cutting, they're burning, they're hitting themselves. There's doing this to seek attention, or they're doing it because of negative feelings. And most important, this is a risk factor for suicide. My suicide lecture is in quite a few weeks, but we'll go over some of this again, talking about suicide. So culture considerations, I think I put that on your lecture note. So the masking of depression by other behaviors considered age appropriate. So a school phobia, their hyperactivity, they're having learning disorders, their grades are failing, and they're antisocial. So a major manifestation among cultures that avoid verbalizing emotion. So this is substance abuse, they're in gangs, there's risk behaviors, there are eating disorders, compulsive behaviors. So we have all kinds of culture that goes along with this depression. So a little bit of data. Major depressive disorder is very common, more than 3 million cases per year. It is treatable, doesn't require a lab test or imaging, can be ages 15 to 45. More common in females. Decreases with age in women. Why do you think it's common in females, Martha? Some kind of ideas.
Maybe related to hormones?
Could be, yeah, that's good, Summer. Yeah, it could be related to hormones. A lot of it, like we said, with the postpartum, right? I know men, when I did home health, the men that had, and we'll talk about this in open heart surgery, when we do that lecture, a lot of men had to go on depression medicine because now they're not able to lift for a while. They can't get back to what they used to do. They get really depressed. They're not supporting the family, so we see that a lot with surgeries with men. So.
Also, women are more open about it too, so men wouldn't report it.
That's good. Yes, you're right about that. Good. To make the diagnostic criteria, they must experience 5 or more symptoms in the same 2-week period. Those of you that have been in psych already, have you seen any depression?
Yes.
Basically everybody.
Yeah.
And do you think, I'm sure I didn't, or did they mention in orientation or your instructors, has it increased this last year and a half with this COVID?
Yes, it has.
It has, yeah.
I assumed it would, but I didn't really hear anybody say, but I'm sure it does, Okay, so that's sad, that we have to worry about that. My sister's in nursing home, and she's not always verbal, but we've seen her decline when we couldn't go see her, because she had no interaction. So it's very sad. So it can be dangerous or life-threatening if untreated. So we definitely. Why I'm thinking about, before I forget, those of you in psych now, I get to go to clinical next Tuesday. My group will be glad to finally get see me there. When you're in psych and you're with Mrs. Music, usually I try to rotate you through the open heart unit so you can see an open heart surgery before I teach about it. Okay. The other ones in Mrs. Bay's class, I also will take you up there too. Okay. So I'll try to make sure everybody gets to see that. It helps a little bit when you see what I was talking about. Okay. So sad mood. This is lack of interest in life or activity, 2 weeks or more. So these are some of their symptoms for the major depressive. Lack of interest in life or activity, 2 weeks or more. Changes in eating habits. They've had a weight gain or a weight loss. Not just a gradual. This is usually a drastic that they see. Sleep changes, hypersomnia, extreme daytime sleepiness, or insomnia, trouble falling or staying asleep. Okay. Mental changes is impaired concentration, decision making, or problem solving. I can't see you guys writing notes. I hate not being in class. Okay, with mood, Heather, what kind of things do you see with mood with them, you think?
Maybe withdrawn, disinterested.
Okay. Worthlessness, hopelessness, despair and guilt. You could have thoughts of death or suicide. Overwhelming fatigue. And negative thinking. Okay, did you guys get that? So now, what is our interventions? So safety, that's always a big thing, right? We want to make, always think when you come to questions, safety, right? I know a lot that does Jumpstart at Ohio Health. A lot of their things is over safety. Is that patient laying in that bed? Are they safe? Side rail up, or, this or that. So safety, suicide precautions, again, we'll get deeper into that in that lecture. But safety is a priority. Common items may be used in self-destructive manner. So things we may not think, they could use them to hurt themselves. Therapeutic relationship. Those of you in psych, you've probably seen the nurses just sit down and talk to these patients, right? I mean, I remember I got pulled down there years ago, and this nurse sat there in the bed beside the patient for almost 2 hours just talking. So that's what they do, therapeutic relationship. They have empathy. Promoting ADLs. Can the client respond with simple tasks? If you say, hand them a washcloth, say, wash your face, can they do it? If you say, here's a washcloth, wash your face, then your arm, then your leg, that may be too much. They may not be able to do multiple tasks at one time. So you may have to do a simple task at a time. Therapeutic communication, again, do not attempt to fix their client's difficulties. You're not there to fix it. You're there to encourage them to describe their feelings, but you're not to fix it. managing medications, always assess suicidal risk. Again, how about the management of side effects of medications? Those of you that did your drug cards, I haven't got to look over all of them yet. A lot of them, the side effect is suicide, right? Suicidal ideations. So we're helping them, but we may give them that side effect. Education promotes compliance. And you'll see this on your med search board, education, it's all about that. And then patient and families teaching. They need to understand depression is an illness. It's better than it used to be years ago. It was like a no-no word, you don't talk mental health. They need to know treatment outcomes and support groups. Any question on that? Okay, some treatments we're going to talk about is ECT, psychotherapy, and hospitalization. ECT is electroconvulsive therapy. So this is used, there's a picture of a guy getting it done. Clients that don't respond to medication, sometimes will give it because the risk of suicide is so great before their meds kick in. So this is like to help them over that threshold. It's changed a lot. I mean, years ago when they went for these treatments, they come out worse than when they had. So it's really evolved. We talked about your extra credit videos. If you found a video long enough on this, there's one of your extra credit ones. You could watch and learn about it and have your extra credit. So anything like that. Psychotherapy is combined with your medications. Like interpersonal therapy talks about difficulties in relationships and friendships. Behavior therapy is reinforcing interactions with the environment. Get them to improve those social skills. Cognitive therapy. How does that person think about their self and others? Okay. And then hospitalization. Again, they may need to be hospitalized to get those meds to start working, get them over that threshold of where they may be a danger to themselves. Okay, psychopharmacology. So this is where we get into each classification. So the choice is going to be based on the symptoms, the age, and the physical health needs. Again, all different kinds of side effects that will go with these. Okay, so we're going to take each one at a time here. SSRI. Selective serotonin reuptake inhibitors. So this is our most frequently prescribed category of antidepressants. Effective for most clients, corrects the chemical imbalances in the brain by blocking the reuptake of serotonin into the neurons. These are considered safer for the older adults because they produce few sedating side effects. So one of them is Prozac. Sure you've heard of that one. They use this a lot for panic attacks, OCD, bulimia, PMS. We used to show videos when we had this in class. This guy with a little bulldog, he was so afraid of dogs, they had to work with him to even touch this little bulldog. If you ever look it up, it's a very interesting video. But they did this with him also. So panic attacks, OCD, bulimia, PMS. Another one you've heard of is Zoloft. This can be PTSD, social phobia. A lot of these are going to treat the same. Paxil, panic attacks, anxiety disorders. Celexa, depression. Lexapro Lexapro is anxiety. This is one I had not heard of. Luvox helps with OCD, helping decrease persistent and unwanted thoughts. And Vilabred is for depression. So I'm sure those of you on psych have seen these meds there. Am I right?
I have a quick question. So is the problem that there's too much serotonin or too little?
Too little. They're trying to help that. I don't know how else to say.
Okay.
Wait a minute, I may be wrong. Blocking the reuptake. Too much. I'm sorry, I told you backwards. So they're wanting to block that's coming in. They're getting too much.
Okay, thank you.
Let me. And these categories are all in the book. Let me tell you the page number, then you can read a bit more about it. 290 in the new book, if you have the new book. Okay. So that's your SSRIs. Okay, your Cilic or Tricilics. These started in the 1950s. They relieve symptoms of hopelessness, helplessness, anhedonia, inappropriate guilt, suicidal ideation, and daily mood variations. We cannot give these concurrently with the MAOIs. We haven't got to those yet. And there's the names of their Elavil, Ascendin, Cinequin, Amitriptyline, Pamelar. Some of these you'll see. And then again, on your patients on your cardiac med surg floor, you're going to see a lot of patients on these too. So that's why with your concept map, I don't know if we really got to go over that really good, any other groups. You want to always have, I won't say emotional, what am I looking for? Some kind of knowledge deficit related to, anxiety, or we want to see something emotional on there also, because every patient has something going on, right? They've been in the hospital for a while, they're missing their family, they're not working, so there's something going on. You're atypical. Used when the client has an adequate response to or side effects from SRRIs. I think that's inadequate. Let me double check. Inadequate response. Sorry. They've tried SRRIs and they cannot do it, so they're going to try them on the atypicals. Effexor, Cymbalta, Wellbutrin. So inadequate response. Or if they have too many side effects from the SRIs. MAOIs, these are used infrequently due to fatal side effects, and they interact with drugs. But they have used them for treatment-resistant depression. So they've tried other things, it's not working, and these seem to work, but you won't see these a whole lot. Marplan, Nardel, Paradate. So what meds have you seen on your patients inside? Those of you that's there. Have you seen any of these?
Yeah.
Yeah? A combination of them, or?
In some, yes.
Yes. So it just kind of depends again what's going on with them. And, yep.
We're seeing a lot of Gen 3s.
Okay. So that is our meds. Again, they're all in your psych book. Make sure you go over them and why they're using them, what they can do.
And
We have a couple.
I'm sorry.
Go ahead.
With the Rimron, isn't that also being used for appetite enhancement though?
I think I have heard that about that.
Okay, because I see doctors right. Okay.
Yeah, it could be. It could be. And I think you're right about that. So, they're not used just for these things, but these are the things used for what we're talking about. How about that? If that makes sense. So. Okay, now with these things, we have a couple problems that can happen. So, crisis and syndrome. MAOIs, you cannot ingest tyrine-containing foods. Because MAOIs block the enzyme that breaks down these in our body. So no strong or aged cheese, no pure meats, no smoked or pickled, no sauces, no soybeans, dried foods, meat tenderizer, alcoholic beverages, or yeast. If they're on MAOIs and they take these, it can send them into a hypertensive crisis. So they really have to watch. Now, who's watching them? You know, are they really watching what they're eating when they're on this because they're so depressed? You know, so it's like a lot of teaching. Are they accountable for what they're eating? And I meant, well, of course, I didn't get to clinical yesterday. Those of you that go to psych next week, see if they have a diet from dietary that they cannot have that shows these foods are not on there or something. See if you can get that for me so I know. And then now we have serotonin syndrome. So this occurs when inadequate washout. When they stop the MAOI meds, they're wanting to start the others. There's not, it's called a washout. So it's 5 to 6 weeks between it. So they can go into this syndrome. Agitation, diaphoresis, almost like a DT problem. A lot of times they'll give them Demerol. Or when they give them Demerol and they're on MAOI, they can cause this syndrome also. So a hypertensive crisis and serotonin syndrome is 2 we have to watch out for. Okay. What time is it? Let's go ahead and take a break before we get into bipolar. And what time is it? 10:41. Okay, let's take a break about